format of an EKG. So EKG we know is measuring the the electrical activity of the heart. And so not only just the electrical activity of the heart, but please understand that this coincides with the cardiac cycle. So by looking at each part of this EKG tells us what's going on during the points of the cardiac cycle through contraction and the points of relaxation. Okay. So it gives us a lot of information. Now, the thing here is that with these individuals, sometimes these individuals could have the electrical activity of the heart can just go a little out of whack, okay? And so in that case, they can have what is called ST elevation, which means that this ST segment will now start to look like this, okay, that I have there in red. So when they have an elevation of the ST segment, please keep in mind that this is telling us that when the heart muscle is trying to go into a state right around the ST segment, into a state of ending contraction and going into a systole to try to relax, it is not doing that, okay? So what happens here is that they do have what is called the ST elevation that shows up on the EKG. Now, the next thing here that's important is something called cardiac biomarkers. I do have this also on the laboratory values, which I'll go over in a second. But with biomarkers, I want you to understand what they are and where they come from, okay? Biomarkers are what happens when the heart muscle tissue itself, when it starts to get to a point of ischemia, not getting the blood flow, the heart muscle tissue actually starts to go through a state of ischemia, necrosis, and yes, it starts to die off and derail. When it derails not only just from the muscle tissue itself, but even down to the muscle fiber. These muscle fibers will start to kind of break off, and then what it will start to release are considered our cardiac enzymes. So it will release troponin, and it will also release CKMB. CKMB and troponin, as you know, are parts of the sarcomere, if you remember that from maybe anatomy or physiology. And those parts of the sarcomere, which makes up the muscle fiber, will actually start to derail. This will start to derail, and these enzymes will actually be secreted, and it can flow through the bloodstream. So when a patient has a presence of biomarkers, and especially elevated troponin and CKMB, this tells us that those muscle fibers are actually broken down, and they have released these enzymes through bloodstream. So positive biomarkers tells us that a patient is definitely having an MI. If you don't get anything else from this, make sure you understand that the presence of biomarkers tells us a patient is having an MI. Not so much the EKG, but it's really just the presence of the biomarkers. So, in this situation here, this person had an ST elevation, positive biomarkers, and so their diagnosis is going to be an ST-EMI, which means ST segment elevation myocardial infarction. Okay, so that's the abbreviation for that. Now, say for example, if a person has the EKG done and they don't have any elevation and the EKG is clear, okay? That doesn't mean that they're okay and they can go home, but they still do have a situation going on. So the situation here is that, okay, let's look at the biomarkers. So you do blood work, you look at the biomarkers, and in this situation they have no biomarkers, okay? So, okay, well that's good, but they're still not in the clear. They're still having chest pain, so what's the problem? The problem here is that they don't have a complete occlusion, they just have a partial occlusion, but the issue here is that they have a partial occlusion, which means that there is still something there that's altering blood flow to the heart. So most of the times when a patient has an unstable angina, just so you can understand, this is definitely indicative of along the lines that they are just going through arthrosclerosis, okay? So when they're just having arthrosclerosis, giving them unstable angina, this means that, yes, you will treat the arthrosclerosis by whatever type of medication and lifestyle modification that they need. Now, if for some reason you get the blood work back, okay, EKG is clear, but they now have positive biomarkers, this is considered an NSTMI, meaning ST segment elevated myocardial infarction. Okay, so that's the name for that one. So, this is just showing you a picture of ST elevation, which I tried to draw over there for you, what it looks like. I'm not so concerned with this slide. You don't have to worry about that too much, and I'm quite sure you guys will get all that information, even into nursing and how to do the leads and all that, what you're looking for. Okay. Now, this is showing you what happens hours of onset of an infarction. So when a person has an infarction, and I can't remember the exact, oh yes, here we go. Right after a person has an MI, these cardiac markers actually stay in the bloodstream for 48 to 72 hours, okay? So these cardiac markers can stay in the bloodstream for 48 to 72 hours. So if a person is having a heart attack and they don't rush to the hospital right away, or sometimes people don't know they're having a heart attack and they just kind of don't feel good the whole day and maybe some pain and, you know, not sure what's going on with them. But when they do get to the doctor or the hospital and get blood work done and they do a cardiac panel, they can see that yes, this person did have a heart attack, okay, just by looking at those enzymes and seeing the elevation, and it does last up to 72 hours. Okay, so that's quite a bit of a time. Now, with this slide here, hurry up, there's a lot of stuff I need to go over. Okay. With this slide here, this goes over pretty much the compensatory mechanism that happens. So let me just explain this to put it in a simple term. So, say for example, the heart is going through a myocardial infarction. Okay. So if it's going through a myocardial infarction, this means that the cardiac output is low. Once the cardiac output is low, what happens is we know that stroke volume and heart rate is a direct relationship to cardiac output. So when the cardiac output is low, the body is going to sense this, and the nervous system, in particular the sympathetic nervous system, will get activated, and it will cause the heart to elevate, or the heart rate to elevate. Cause the heart to contract, contract, contract as fast as it can. So sometimes these patients can get maybe a little tachycardia because of what's going on, because of the compensatory mechanism, even though yes, they're going through an MI, they can have a little bit of that too. So the sympathetic nervous system activation will lead to an increased myocardial workload, which will then increase the heart rate, increase the contractility of the heart muscle tissue, and obviously also increase blood pressure. Okay. So just make sure you go over those things. Now, please understand this diagram, and I know it looks like a lot here, but if you walk yourself through it, it's not that bad. Okay, so let me just go through a little bit of this so you can understand. When we have a decrease of myocardial perfusion, okay, decrease in blood flow to the heart, this means two ways it can go. We can have partially occlusion or a total occlusion. When there's partial occlusion, what happens here is that the blood is not getting to the tissues fast enough, and so the tissues undergo a state of anaerobic metabolism because it doesn't have enough oxygenated blood. So when it goes through anaerobic metabolism, it will accumulate lactic acid. That lactic acid will then inhibit glycolysis, which therefore reduces ATP. When ATP is reduced, ATP, as you know, is needed for the membranes, and we went over this week 1, and it's needed for the membranes and also for the membrane channels, okay? And so what will happen here is that it will now have a faulty ion pump, therefore the ions will start to leak. When we have leaky ions, or I should say leaky ions, but ions start to leak because of faulty pumps, what happens here is that you will have now this offset of the sodium, the potassium, and all those ions that actually are part of muscle contraction. So the muscle will not be able to contract as it should because the ions are actually a little off whack. So This will now show changes, obviously, in the electrical rhythm of the heart. So you'll see problems on the EKG, and obviously dysrhythmias, okay, all because of ions. The other thing here is that these patients that have a total ischemic or total occlusion will definitely have no ATP. We know that it will disrupt the membrane and make the cells die because the pumps and channels on the membrane are not working and it's done, and so the cell is not going to be able to get what it needs to get. And when the cell and tissue starts to die, it will release those cardiac biomarkers that I told you before, release it into the bloodstream, okay? And then it can also offset the ECG, and it can also cause the sympathetic nervous system to make the heart rate elevate, giving them a tachycardia, and also causing vasoconstriction, okay? So this is not as bad as it looks. I think you'll understand it when you get through it. Okay. And this is another one that just kind of goes over the same exact thing, but it puts it in a little different version. And it even adds in here for you the renin-angiotensin-aldosterone system and how that's affected, okay? And we know the way that will get affected is it will cause fluid retention, and then when you have fluid retention, that elevates the blood pressure. Now, sudden cardiac death. Okay, so sometimes patients can just, unfortunately, drop dead. Okay, and how does that happen? Why do they just drop dead? What happens here is that there are certain things that can cause a person to lead or go into a sudden cardiac death. Obviously, if they have a full occlusion, okay, no blood flow is getting to the area, but there are some risk factors and things that can put them in that state of a full occlusion. Okay, so we'll go over this. And this is unexpected death, okay, in 1 hour, okay, of symptom onset. The way you try to revive these patients, obviously, as you know, with the defibrillator and CPR. Okay, now, causes, if you want to jot this down, the causes here are going to be, number one, multi-vessel arteriosclerosis. Okay, so multi-vessel arteriosclerosis. Obviously, multi-vessel arteriosclerosis, if we have obviously a blockage, okay, and a whole bunch of vessels, that's obviously going to lead to just a little bit of blood getting to the heart. Another cause is going to be diffuse myocardial atrophy. Diffuse myocardial atrophy, and what that means is, this means that the muscle of the heart is in a state of atrophy, is small, is not functional, which means that the heart is not going to be able to contract as it should. So therefore, the heart is in a state of, we can say, disuse. Okay. Scarring, sometimes scarring from prior surgeries. Fibrous of an old MI. So when patients do have myocardial infarctions, they do start to build up scarring or fibrosis right where they had the MI or where that tissue became necrotic. Keep in mind that, and I'm quite sure you've heard of, that sometimes when patients have an MI and surgeons may go in and look or whatever, and they can tell where the patient had an old MI because there will be some sort of fibrosis there. And then also electrolyte imbalance. Okay, so we just talked about not too long ago what happens with the ions, and if the ions get off whack. And so if you are missing those basic electrolytes like sodium, potassium, calcium, those things that are needed for muscle contraction, yes, that will definitely lead a person into cardiac issues and possibly death. Okay. So, chronic ischemic cardiomyopathy, what does this mean? Okay. This is not really saying much. It's just saying that sometimes elderly patients can sort of get this sort of chronic ischemia that can get to the heart. And it's just because over time, the vessels can actually just get into more of a vasospasm. Maybe the blood's getting a little stagnant, blood flow perfusion rate is not that great. So these things can happen with older individuals, and they can have angina and maybe prior MIs, okay, to that. Now, because this isn't a full class, I don't have to take a break, so I can just go right through. The next thing that I'm going to do, and let me just get my bearings here. I want to go through Bowel of Diseases. So we're going to talk about what happens when the valves are not functioning in the heart. And then we're going to go over endocardial diseases. I am going to leave out, because unfortunately, even though I am recording this, I am still also on the time constraint right now, because I do have to record week 4 and 5 together. And so what I'm going to do is hold off on myocardial diseases, and you can tell, I'll try to tell Mrs. Felton if I can remember, that I'm just going to hold off on that for right now. Let me see if I can get through it. I think I'm going to try to hold off on myocardial diseases. So, let's do endocardial diseases, okay? So what happens here with, about valvular diseases. So we know that the heart has 2 sets of valves, okay? So we have our AV valves on the right and left side, and then we also have our semilunar valves, aortic and pulmonary. So keep in mind that these valves, we all know that they open and close to get blood flowing in the direction that it needs to go to, and obviously we don't want to have any type of regurgitation. But sometimes these valves can have issues. They can get stuck, they can get stenotic, they cannot open properly, okay? So certain things can happen with these valves, and this is what we want to go over. Okay, now, stenosis. Stenosis is going to be a failure of a valve to open completely, meaning that there would be extra pressure work from the heart. So what happens here, when something's stenotic, say for example we have our valve and it's maybe sitting like this, and we want to open the valve, but for some reason that valve is stuck and it won't open. Sometimes when valves are stenotic, that means something could be sitting there, okay, causing an issue. Excuse me. Or for some reason it's just rigid. Okay. Now, we also have the term regurgitation. Regurgitation means that this is the inability of a valve to close completely due to extra workload on the heart. So now we have a valve that's open, it opens up, but when it's time to close, it doesn't close all the way. Okay, so then it stays open, and then now keep in mind that blood is still doing and circulation is still going on. So then when we have blood that's trying to move, okay, from here and trying to move forward, it now causes a regurgitation of that blood going back through the valve. So that could be an issue. Now, another thing I want to go over, the difference between, or the term that we call a heart murmur, okay? So when a person says, oh, I have a heart murmur, that just means that a murmur is just the abnormal sound that's heard on the heart, okay? It's just the abnormal sound heard on the heart. It does not mean that, okay, well, that's the diagnosis, but it's saying that, yes, something is wrong with one of the valves, okay? And then you have to do further testing to see, okay, well, which valve is it, right, and what's going on. Now, keep in mind that EKGs are very good for electrical conductivity of the heart and knowing the activity of it. But the best way to look at these valves and see how they're moving and see if blood is flowing through or not is doing an echocardiogram, the ultrasound of the heart, okay? So when that is done, that actually would give a nice picture of the movement of these valves, okay, to see if it's stenotic or not, or if there's some sort of regurgitation. So I do need to draw for you guys. Really quickly the heart. I know my heart rate's funny. It looks like smiley face. Okay, so the reason why I'm drawing this heart for you guys is because we are going to go over all the different valvular diseases. And what I need you to know is not only the names of the valvular diseases, but I do need you to understand what's going on, and then if there's a regurgitation into which chambers of the heart, and pretty much what's going on with the heart, okay, in that valvular disease. So please understand, and I will test you this way, making sure that you understand, okay, well, where's the regurgitation happening? Is there a black flow going into different chambers? Is it causing left-sided heart failure, right-sided heart failure? Is it now really getting to the lungs? Okay, so what is it that's going on with that particular valvular disease? Okay, so the first one we have is called mitral stenosis. Okay, mitral stenosis, this is talking about the mitral valve, which you know is also known as the left AV valve, also known as the bicuspid valve. Okay, so remember it has three names: left AV valve, bicuspid, and we commonly know it as the mitral valve. So what they're saying here with the mitral stenosis is that this mitral valve will be stenotic, which means that it is not opening up all the way. And so because this valve is not opening up all the way, what happens here is that blood flow from the left atrium to the left ventricle is impaired, okay, during diastole. So when it's time to relax, okay, and move and get that blood forward, the problem here is that it will not move forward as it should. Therefore, it will increase pressure in the left atrium, lead to atrial chamber enlargement and hypertrophy. So let's just go here. This valve is stenotic, okay, which means it's not opening up as it should. And so what's going to happen here is the blood that's in the left atrium is not moving forward like it's supposed to, and it will just stay here and pull up. So when this blood stays here and pulls up, it'll actually cause the left atrium to go into a state of hypertrophy and get very large. Now, the other issue here is that blood that's coming in from the left atrium, we know, gets dumped from pulmonary veins. So pulmonary veins can also now get backed up with blood. And where are pulmonary veins coming from? They're coming from the lung. So keep in mind that this can also lead into what is called the chronic pulmonary hypertension, meaning that this whole backflow of blood can cause a lot of pressure, too much pressure, and then cause what is considered pulmonary hypertension, okay, with that blood flow coming from the lungs. It can also lead into a right ventricular hypertrophy and right-sided heart failure, because keep in mind, all of this blood was coming from the right side. So if it gets that bad, it can back up from the lung, back up all the way back to the right side of the heart, and cause now right-sided failure or hypertrophy. Okay, so I hope you understand that. Now, for test purposes, I do also want you to know the sounds of the heart, okay, or the sounds of these valvular diseases. Now, I usually show, they have some YouTube videos that goes over the sounds. Not that I'm going to put sounds on the test, but if you're interested, you can look them up and hear what the sounds are. For the sake of time, I don't have time to have you listen to each and every sound, but I'm quite sure you'll get that information in nursing. But in any event, please memorize the way the description of the sounds are. So low pitch, rumbling, diastolic murmur. I know you don't know what that means, but what happens here is that it's a low sound. It sounds kind of rumbling noise, okay? And it's diastolic murmur, meaning that when the heart is now in a state of relaxation, that's when this murmur happens. So just make sure you memorize this, okay? And again, not that I'm going to have sounds on the test. I would like to do that, but I don't have the capability of that right now. But just make sure you know the description. Okay, so there's a picture there. Now, the next one is mitral regurgitation, okay? Mitral regurgitation, what does this mean? This means that this mitral valve here, so we're going back to the mitral valve. This mitral valve here, it opens up, okay, to get the blood flow through here, but the problem is that it will not close properly, okay? So therefore, the blood that gets into the left atrium, left ventricle now, goes back and regurgitates back up to the atrium. So in this situation, okay, backflow of blood from the left ventricle to the left atrium, and the left atrium and ventricle will now both dilate. So the problem here is that when we have blood here, because this valve is open, and so it's really going to offset even the contraction, so there's no movement of blood whatsoever. So the blood is just kind of stuck here, and then not only that, it will kind of go back, okay, up into this atrium. So we'll have blood here and also blood here. So it'll cause this whole left side of the heart to get dilated because it's all filled with blood and go into a state of hypertrophy. Okay. This could lead to left-sided heart failure, and the description of the sounds are here. High-pitched, pansystolic, blowing murmur. Okay. So again, just please memorize the sounds because I will test you on that. Okay. Mitral valve prolapse, this is one murmur that is actually quite common. And with mitral valve prolapse, this particular one, this means that, say for example, the valve sits like this, okay, but with the mitral valve prolapse, the valve is not in its proper orientation and it actually sits like this, okay. So if the orientation is off, this is obviously going to alter the way it opens and closes. So with mitral valve prolapse, this is a displacement of the leaflets, okay, of the valve. And what happens here, because of this, obviously, the patients will get a regurgitation of blood, okay, going back up to the left atrium, much like the mitral regurgitation. So sometimes this is asymptomatic. Patients don't know that they have this. They usually don't have many signs or symptoms from it. But when they do find out that they do have this murmur, sometimes it is found on routine exam by listening to the heart, and they do find that there is a problem there. But the issue here is that there are some complications that can happen from this murmur. And so one complication is something called infective endocarditis, which we'll go over in detail in a little bit. And so what that means is that because these leaflets are displaced, what happens is that when blood flow and circulation is going through the body, what happens is that, say for example, if this person is now infected with some sort of bacterial infection, when those bacteria and those microbes flow through the bloodstream, because of the orientation of that valve, it'll actually just kind of predispose and just get kind of stuck there, okay? So now they can have bacterial, just vegetative states just sitting right on those valves. So that is a complication of mitral valve prolapse. Hence the reason why, if you've ever heard patients that have mitral valve prolapse, that they do take antibiotics, okay, right before any type of surgery or dental work and things of that nature, just to prevent that type of situation. Now, sometimes it can get terrible where they can get into a cardiac death or embolism, or get into a really progressive regurgitation, okay, and have a whole bunch of signs and symptoms there. So the sound here is something called a mid-systolic click. And what happens here, you'll hear sort of lub-dub, lub-dub, lub-dub click, lub-dub click, lub-dub click. Okay, so it's an extra sort of beat that happens after the normal lub-dub. Okay, S1 and S2 heart sounds, if you're ready. Now, the next one here is aortic stenosis. So with aortic stenosis, they have here, this is predominantly caused from age-related calcium deposits, okay, in the aortic cusp. So what does that mean? That means that when these individuals have, say for example, we would say the elderly people, okay, may be more predisposed to this. So say for example, an elderly person is going through maybe a state of osteoporosis, the bone is breaking down, and we are releasing more calcium into the bloodstream. When this calcium gets released into the bloodstream, this calcium can, unfortunately, now deposit and pull up right around the aortic semilunar valves, okay? So remember those valves are sort of a half moon shape, sort of like a cup, And so those calcium deposits can just kind of sit right there. When those calcium deposits sit there, obviously this will obstruct blood flow getting through the aorta. So if we obstruct blood flow getting through the aorta, we know that this will lead to an ischemic situation. So which means that all the organs and whatever's supposed to get blood flow coming from the aorta will now go into a state of ischemia. The other thing here is that this person can get left-sided heart failure. Why? Because what will happen here, the blood that's in here is not going to be able to push through, so it's going to stay in the left ventricle and then most likely regurgitate back or cause just a whole dilation here. Okay, it would just be a cascade effect. Now, the sound here is something called crescendo decrescendo murmur, which means that it'll sound high and low, high and low. Okay, so this is the murmur that is heard with aortic stenosis. And then aortic regurgitation . Okay, aortic regurgitation, this is when the aortic valves do not close all the way and they're incompetent. And so what happens here is that the blood that's in the aorta, okay, is here, but because this valve is open, it will now start to leak blood back into the left ventricle, okay, because those valves are just stuck open. So what happens here, yes, this can lead to left ventricular hypertrophy and dilation, and obviously can lead to left-sided heart failure. So they can have a high-pitched blowing murmur with this. So it'll sound very high, it'll sound like a blowing sound that goes through the lub dub, and that's the murmur that is heard. Okay. Now, the last two things I want to go over with 18, and I'm going to stop here, like I said, for the sake of time, and don't worry, when I do the review, you'll understand exactly where I'm leaving off. So, okay, so let's just talk about the two endocardial diseases, okay, and then we're going to stop here for 18. The first disease that's listed here is something called rheumatic heart disease. Okay, and rheumatic heart disease, this is an acute inflammation that happens, or an infection that comes from group A beta hemolytic streptococcus. Okay, and if you went over that in micro, you know what it is. And basically what